Proceeding on to the next section, we will do just a small informal discussion on anesthesia. So, as Paul said, that we are very fortunate that we have a full anesthesia team. Dr. Professor Safia is the head of anesthesia here. So we don't have any problems with sedation or patient not coping properly. If even if you're doing a patient under sedation, if we think that it requires anesthesia, we just call them and they give the anesthesia, and it makes it a lot easier for us to do the procedure. So I think when we asked you, none of you have anesthesia cover for your list. सब लोग sedation में ही करते हैं. Everybody does it under sedation. तो रफली सिडेशन में व्हाट वुड यू से कि कितना सिडेशन देते हैं? तो रफली कितना, जैसे एवरेज जैसे होता है, जैसे हम लोग करते हैं कि जी एवरेज सिडेशन आपकी क्या है मिडाजोलैम और किन्स की? 2 mg किन्स. एवरीबडी एल्स कोई ज़्यादा देता हो, कम देता हो? सेम? हाँ, सेम. 1 से स्टार्ट करते हैं. सही.
Thank you, Shanil. Thank you, Paul, for coming here and teaching us so many things. And I am Dr. Safia Zafar, anesthetist here. And we have a team of 6 anesthetists here. And what do you think? Is it necessary to give sedation or anesthesia for colonoscopy? Is it necessary? Yes? Why?
It can be painful, and Keynes gives some level of amnesia as well. So it's like easier for the patient to go.
And what do you think? 2 milligram Kins is enough for an adult for pain relief?
Ma'am, I think so.
I don't think so. Yes, I totally agree with you. 2 milligram cage is not enough. It is, but it is working. When it is working, of course it is working. It is working in combination with the as well. And it produces amnesia and insulinsis that will cause pain in the patient. So that combination is very good. 2 milligram methylene, 2 milligram pain, or if you want, you can give 2, 3, 4 milligram of pain. But be careful, it may cause apnea. And you people should be more careful about apnea, because you are doing colonoscopy, not bothering the patient is breathing or not, what is the saturation, what is the hemodynamics. So be careful for this. And if you need, you can call us for your help. You can have anesthesia technician, trained anesthesia technician in your OR to provide oxygen to these patients. If there is a little respiratory depression for some time, oxygen will cover all these things. So the oxygen is must. I think oxygen is must. Bidiesel cannula, 2, 3, 4 liter of oxygen is enough just for safety of the patient. So our priority is safety of the patient. Our the safety is must because there are we are not giving anesthesia, just sedation. I'm talking about sedation, uh, and you people are giving this. There is no anesthesia cover around, so safety is must. And if the patient is still uncomfortable, to don't give too, more than 2, 3, 4 milligram of midazolam. It will cause sedation and respiratory depression in combination with nalbuphine kins. So be careful for this. And if you need uh, more cover, you can call us. We will provide these things. Okay. And
Usually people say first give kins and then give midazolam, or because of the synergistic effect, or because like we give fentanyl first and then we give midazolam. Is there? Is, would you say that they need
and
to give, or
any combination,
any
any combination, and give in titrating dose. It is not the rule. Give 2 milligram of this, 2 milligram of this. It is not good. Patient's body weight is very important, and as Paul said, it is more for the respect of the patient. If the patient is female, young, anxiolysis is must. So give some drug, and counseling is must. Uh, it will cause good effect on the patient. Yes, all these things. And especially in obese patient, when there is short neck, patient is lying this, and there can be chance of choking airway. So be careful for this. And mm,
might not be able to do a colonoscopy with sedation alone, or if they already have a history that I had a colonoscopy previously and it was such a horrible experience and I don't want to go over it again, then that they need either higher sedation or they need an anesthesia. So for those who don't have a anesthesia covered, like they have to call the anesthetist for it. No, you need to just plan the procedure properly, because there's no point getting all patients' preparation and everything, bringing them, and then you've gone into sigmoid, and then you find out, oh no, this patient can't tolerate the procedure. So the patient's taken all the preparation, their experience is not good. You've already done half of the case, and patient might not come back again. So when you're booking the patient, as Dr. Mansoor and Professor Sagda said, Sophia said that when you're booking the patient, that is the time where you decide. This is the patient I'm going to do it under anesthesia. This is the patient I'm going to do it under sedation, and then, as Paul said, we usually start with the low dose and go up to higher dose. The other important thing is having antidote. If you're giving midazolam, you need to have the antidotes. If you're getting Kings, flumazenil and naloxone. If you don't have it, you have to go and get it from pharmacy. Then that's no point, no? Huh. Huh. Not available pharmacy, so it has to be there. Okay, if you need it, nobody is going to pharmacy and going and getting it. It has to be there in the room.
Goodell's airway and LMA. It is must to have you. Goodell's airway is very easy to introduce, and LMA is also very easy. Anybody can introduce it, and you can learn it in theater. You can learn it from us how to introduce LMA just to save the patient.
Should be because if you call Professor Sapia, the patient is desaturating, come and go it. She'll have to bring everything with her. she needs to know that at least you have something there which she can do it quickly, so that, and then call the team and everything. So if you don't have anything there, then there's no, you should not be doing it. You have the whole room properly set up.
And be careful in diabetic patients because they are not eating since last 1 day or 2 day. I have seen patient with the random blood sugar level of 20, 28, 30 before start of colonoscopy. I have seen it here. So just see what is the level of blood sugar level at this moment, and then to give some sugar, then start. Otherwise, you think the patient is unconscious because of your drug, Kins or Domicum, and patient is hypoglycemic. So be careful in diabetic patient as well.
A lot of people do the diabetic patient first on the list. So if they know that your patient is diabetic, they'll put them first on the list so that they do it early in the morning, and then they can do the other patients.
And if you are doing colonoscopy in a child, 10 years, 12 years, then these drugs are more than enough for them. To be careful for these patients. Give a small under anesthesia. Yes, desedation. Okay. I will put a leaflet in your file. What is the? There's few questions in it. One question is what is the safe sedation? Safe sedation is when the patient is maintaining is the hemodynamics, blood pressure, heart rate, and saturation. These things should be maintained, and you should keep an eye on these things on the monitors as well. Yes, yes, but you cannot give more drug.
So what about nose spa? Does anybody give nose spa before starting or during the colonoscopy? No, like they doesn't Buscopan doesn't come IV here, but nose spa does. Anybody does? No? What Paul, do you? Warm water.
Then they say continue or not continue, just pause. And it's nice to have that support that you're not doing something wrong and that you're going down. The biggest thing that I'd like to remind you is what's been said and been missed by you guys. But it was emphasised when she was talking about looking at the patient, seeing the neck is small, seeing how they actually sit, looking at the weight. The word there is look. And the biggest thing that you've got is that people don't look at the patients. The word look at the patient is that they look at the notes. Look at the patient. Look what you think is the right thing. That is the key. That's what she said to do. Look at the patient. Look at the notes. Take out plans that you think that this is the right thing. Or this is the weight, this is their age, this is what should take. Look at
And keep talking with the patient. Keep talking is very important. It, it, it is sure that the patient airway is clear, patient is oriented, and anything Okay, you are comfortable. I am finishing your procedure. Keep talking. Then it will be comfortable for the patient as well. Mild sedation. You are doing mild sedation, not full sedation. Full sedation is not recommended by you people. Huh. Huh.
When and when we have to totally address it.
I think you people can give mild sedation, not full sedation or anesthesia. Okay, thank you. Any question? No? Thank you.
So we have Paul. We have a short presentation by Paul about consent and complications. If you look at your folder, there are multiple forms in the folder. So I just wanted to ask you, there is a at the end of the folder there is an anesthesia form, which if you could fill and just give it to us. It's just like a survey about what your experience is on anesthesia. And then there is a JAG form, which is a DOPS form. So when you are doing the cases, you need after the case you need to get one of the consultant who is doing the case with you to sign that DOPS form with you. Okay, so you know what you've done, what you need to improve. There is also a trainer feedback form. So we want you to give us a feedback on the trainer who was training you. This is all anonymous, so no, there is no names or anything like that. And then there is another form which is evaluation form. So we want to know what you thought about this course, and what why did you come to this course, and all that. So if you can just fill out, make sure just you fill out these forms and just drop it out, and then we'll pick it up. But the DOPS form is mandatory, so just make sure you've done the DOPS form. Thank you, Dr. Safia.